I want to say a word of thanks to the organizers for inviting me on this time of a Friday. I thought those of you that attend church would agree that while people enter, maybe we can sing a hymn. I don't know what type of scientific health hymn we can sing, but the alternative is just to settle and say this is the congregation, and then we go ahead with that. The talk is about doing research in context, and I was happy to be in the previous sessions, and some of the work, especially that the last speaker, Dr. Makama, was talking about, you will find some of this here. I must say, I thought at one stage whether the mosquito should go to the Airbus factory and assist with the development of new flying machines, but probably that's taking things a bit too far in terms of research in context. So the purpose is to talk about community-oriented primary care. And I am assuming that most of you, this is not something that you work with every day. And if I explain things a bit more than you think is necessary, just live with us. And the whole issue is, how do we do research in that context? Now, life as we live it in our work is about research, and I made it biggest for this place and this session. It's about service delivery and about learning. And for us in primary care, those elements are essential to be present when we work. The most difficult one of those are the middle one, and that's the actual service delivery. And I think what I want to bring into the discussion specifically is how we do research in the midst of service delivery. For us it's a lot about place. Now I know it's Rugby World Cup and, but this is about soccer. And what I wanted to allude to is that a lot of what we do relates to the place where we do it. This is putting a match together between the epidemics and the health team. And the point that we are making is that a lot of this game, the health team has been playing in our own area, big hospital, big university, laboratories, etc. While the real game is in the community where the epidemics are rife. So the first thing that we did in response to the re-engineering of primary health care is to say the most important shift is a place shift, to move from there to there. So in terms of the metaphor of a soccer game, there are those three things that I referred to. The first one is place. The second one is that it's actually about the goal. Now, I know that I talk mostly to scientists and not soccer coaches, but you would know about some teams that play nice soccer, but they don't score goals, and that doesn't really help. you know, we won't mention names. We won't mention names. The point of health is that it happens in people's homes and places where they work. So we say we should understand health and healthcare and reach the home. I sometimes say to students that doing a home visit is the same as doing a laparotomy in an acute abdomen. You can do scans, you can do blood tests, you can do examinations, you can do all sorts of things, but sometimes only when you open that abdomen, you see what's going on. And that's what happens with home visits. Now, with the re-engineering of primary health care, the Department of Health has opened, I think probably for the first time, the chance to do organized community-oriented primary care, where we go to the home in an organized manner. And you know that homes are in different formats. And I'll also talk specifically about where there's no home, which often is where there's most disease. The other part of this is that, I'm just going back, is I said it's about place, it's about reaching the home, and the other one is it's about integration. You only score well on a soccer field if you can pass the ball. It's no use having a good run and then you waste the pass. And passing it means you need to be able to pass the ball so that your co-player can actually receive that ball and play with it. So those are some of the elements that we built into community-oriented primary care. So what is community-oriented primary care? It's internationally recognized. It's an integrated approach to primary health care, and it brings health and other professionals, organizations, and people together. And that point of a defined geographical area is important. It's a geographic thing to identify and respond systematically to health needs. So it's about place, it's about integration, it's about generalism, but it's also about scale. Doing community-oriented primary health care in Tshwane means that we have to aim to reach at least 60 to 70% of the 3 million people in the city. So it's not something we can do a touch of and think we've done it. The other thing of primary care, we talk about high touch, high tech. So it's really about care, but how you organize it and how you integrate it with technology. There are 5 principles of community-oriented primary care, of which the first one is that it's a local health and institution analysis. And I'll explain later how this local geographic is a crucial thing, because that is what defines it. The second one, it's comprehensive. It's from prevention to curative, any disease, any type of problem. More than half of what we pick up is actually social issues. So, in community-oriented primary care, we don't do vertical programs. We regard vertical programs as problematic, as overused, as toxic. We need to address all issues, and then, depending on the local assessment, you would have focus areas. The other one is equity. Health is all about addressing those who are most ill. And unfortunately, in South Africa, most of the health expenditure is done on people who aren't ill. But I'm not talking about that today. The other one is you practice with science. It's about interprofessional, scientific approach. And the last one is that it's integration around users. It's about people, about families. How does the teams work in Tshwane? Just very quickly, there's a geographical area, people's homes. We've got community health worker teams. They work in a specific area. Community health worker will get roughly 200 stands to work with. They go and do home visits. They go into the homes, assess that. They do data collection on cell phones, and then we work out of that. Data and ICT in our approach is crucial. We said high touch, high tech, and what we usually say is when I put in fuel at the garage, my wife knows what I'm doing because she gets an SMS, because the money belongs to her, right? Now, if that's good for money, it should be good for people. So that is our approach, to conceptualize the use of ICT in a way that makes people respond better to health, and especially those in most need. We do household assessment, individual assessments. That goes to a website, and the team leaders and the clinicians get the data and they can work with it. And then we also have different systems that connect between clinics and hospitals and the homes. But Matthew will also talk more about that. That's where our partnership began. And then the analysis of the data is the big thing, because it's actually about making assessments and making plans. And I tell you, at the moment, I've got a lot of discomfort because we are aware of many, many problems at the moment that we can't address yet because we are at the beginning of a project. So it is data with the priority on service. So it's not survey stuff, it's service stuff. But I have to respond to all you biological scientists also and share with you a theory of context. Now I'm going to because in many other places I ask the question, can I just see, whom of you know what a biofilm is and how it works? Just get an indication. I thought when I saw what book you're reading, you will know. But is it really 2 people? Okay, all right. The point is, what Dr. Matama was talking about, you remember that slide he had with the networks that they're creating and then they put the cells in there? That's trying to create a biofilm. When I learned about biofilm, I thought, wow, this is something about communities. A biofilm is microorganisms that organize differently when they attach to a surface. There are the stages of development. It's from attachment to matrix, proliferation, maturation, etc. But the important thing is, and I must say, colleague, I find it very noticeable that even biological scientists do not work with the concept of biofilm. And maybe that says something about our paradigm of thinking, but the point is that microorganisms undergo profound changes during their transition from planktonic free-swimming organisms to cells that are part of a complex surface-attached community. Now, my colleague in immunology at UP told me about this thing, and that helped me a lot. But what she said is that you cannot think you've studied a microorganism if you haven't studied that in a biofilm. And I think that was what Dr. Makama also was talking about. Because, and what's important, a biofilm needs a surface. It develops over time. It creates a matrix, a structure, and then you've got physiologically and behaviorally integrated communities where the actual physiology, behavior, and sometimes even the genetics of organisms would change. The fluid moved between, and then they would release cells and segments of biofilm. Now, just to make life simple for you, the most known pathogenic biofilm that we work with every day is plaque on your teeth. That's why you floss and you brush. All right. And then there's healthy biofilms. So what I do in this argument is to say that you get two ways in which organism exists, simplified, biofilm and free swimming. And translate that understanding to human life that we work with. Also in terms of care, learning, and research. And what I found then, and I must say this has been put very clearly in my mind when we started to work specifically in community-oriented primary care in the inner city, is just that understanding that what we see at the hospital and the clinic are free-swimming organisms, but the real life is a biofilm of complexities. And if you look at the inner city, we've got surfaces there of homeless people, streets, parks, bridges. How many minutes? Thanks. I'll move. Commercial sex workers in 30 sites, parks, buildings, brothels, 1,400 people just in the inner city involved in commercial sex works, injecting addicts, 30 sites, 400 people, Niobe users probably in the region of 2,000. The other thing in the inner city is there's a lot of apartment buildings. So TB, HIV, teenage pregnancy, violence, addictions, mental illness is completely differently linked in real life than what you see in the hospital. I mean, many of those people wouldn't even go to a clinic. They just wouldn't go. This is just the population pyramid in the inner city. Just for example, our data you see on the right-hand side is the whole of Tshwane, on the left-hand side in the inner city, many more young females and few older people. And if you look at our data that we work with in terms of pregnancy and antenatal, this is the whole Tshwane. If you look at the inner city, large proportion of young pregnant girls who none of those go into antenatal care. So the point is, and with COPC we grow a biofilm. Let me make it simple and say, the point is, with understanding communities by going in and getting real data on what's happening on the ground, we understand that what happens in the inner city is significantly different from what happens in Mamelodi, different from Atteridgeville, different from the... And what we need to build is health systems that respond to those. And this is what COPC is. To build a healthy biofilm in the midst of the unhealthy biofilms that are there. So we've got a response in the inner city of including street medicine, mobile clinics, etc., referrals and that. I think we also need to understand in our work that there are biofilms in health that's different. If you look at the tertiary hospital, university, medical school, it's a different biofilm. Things act differently. People act differently. The private healthcare system is a complete different biofilm from what you get in the inner city. And I think we also have to ask ourselves, what are the research biofilms that we function in? Always think about what is the surface where it attaches, what matrix and what structure. So we just now have approved a COPC research unit in the University of Pretoria, which runs through our department, and this is the collaboration we have with the CSIR. It functions within the Tshwane COPC Living Laboratory. It integrates service delivery and research, and we have an integrated ICT platform. And education is part of it. So what we are doing is to create a research environment that lives in the same biofilm where the community lives. And this is what we hope to work with. I'm sure my 8 minutes is now 3. Okay, now it's still 4, that's okay. Let me just give you some examples. The work we do with the CSIR, there's an Umbiflow project in Mamelodi. This is a technology which screens women for undetected growth retardation. It's a sonar technology that was developed here. We test it in Mamelodi and we compare outcomes. And the early signs that we get is that this could make a massive difference in picking up those babies who die before birth, which we couldn't pick up in any other way. But the point here is we can now follow the woman from being pregnant to the clinic, to the hospital, baby being born, baby being seen at the home, and with the pediatric colleagues, we will follow up these babies for at least 5 years. So we can now start doing the science, not just looking at the outcome of the birth, but actually the development of the child, which changes the whole scientific model, that you're not looking at what pitches at the service, but you look at what actually happened in the homes. We've got another one which is just completed. It's to screen hearing at home through smartphone technology. And we have shown that hearing screening allow community health workers to bring hearing health care to underserved communities at the primary care level. The community health worker is being taught to do the screening with the technology that's developed on a cell phone in the home, and we can refer the patients. There are several such technologies in terms of screening for cervical cancer, etc., and this is the type of work we do. We are in discussion now to create a biobank between genomics, cellular and molecular medicine, and our research unit, which means that we can start to do this type of work over a whole population. And we can sample from information. So if you want somebody with this age, with this risk profile, etc., and do work on that, that's what we can do. So in conclusion, we say as health workers and researchers, we are challenged to create and to respond to the unhealthy biofilms and actually link what we know in laboratories to what we know at communities. To build and research caring, learning biofilms on the same surfaces as the unhealthy biofilms. And the important question for me is, will we be able to start to integrate different biofilms in addressing diseases and unhealthiness where it's actually lived? Thank you, Madam Chair.